Hey, Dr. Alan Christianson here with you. I want to take a deep dive with you on thyroid testing. This is a critical topic. People have an understanding now that their thyroid can be the key behind just being healthy and being at a good weight and having energy, avoiding chronic disease. People also get that it's not always clear who has thyroid disease, who doesn't, and of those who know they do, it's not always clear whether or not they're on the best treatment or whether the thyroid is still the culprit for symptoms or not. So to answer those questions, it takes testing. And people now have gotten a sense that testing doesn't come automatically. Unfortunately, many doctors may not do the most thorough tests. They may not read the tests with an eye for optimal levels. And so it's critical to really understand what tests to do, how to make sense about them. And let's go on that journey and give you some good clarity on this super important topic. So a lot of the concepts that I'll be talking about will be much more straightforward if we've got a little preface on the thyroid gland and how it works and what it does. So for starters, you got this thing right around here, about butterfly shaped. It makes hormones that govern metabolism. So I won't go too deep into some of those basics beyond that. I've done that elsewhere. But here are some things that are relevant to the testing. So the thyroid, one of its first steps is that it absorbs iodine. That's a mineral. We get it from our diets. Our intestinal tract puts it in our bloodstream, and our thyroid pumps it inside of itself, and it concentrates that. So once it's got iodine inside of itself, it uses that to synthesize hormones. So it takes building blocks, thyroglobulin, and then enzymes, thyroid peroxidase, to put iodine together with an amino acid called tyrosine and make these various hormones. So iodinated tyrosine with 4 iodines on this template of thyroglobulin is T4. So 4 for 4 iodines. You take one of those off, you've got T3. You break that thing in half into 2 pieces, you've got T2. So that's what all those numbers, those T numbers mean. Now, once the hormones are made and manufactured, then they're secreted. They're released throughout your bloodstream, all throughout your body, to where they do all these various jobs. And the main way they're secreted is by TSH. So this is thyroid stimulating hormone. This is a pituitary hormone, and it comes from the pituitary inside your brain. When it's there, it stimulates the thyroid. And it stimulates it to basically open up, release the hormone, but also to grow new cells, to actually enlarge in its size and increase its total size and its physical mass. The next thing we think about is hormone conversion. So your thyroid hormones are super critical. They're also really powerful. There's a whole lot of redundancy built into this system. What I mean by that is you make way more thyroid hormone than you ever expect to need. And most of it you make in the form of T4. So that's made in the gland and released. Now your gland also releases some T3 and some T2. Those are the more active hormones. We now know that T4 is actually important in its own right. Your brain, your bones, your endothelial lining of your blood vessels, they all need T4 for good function. But a lot of what T4 does is through what you make T4 into, the T3 and the T2. Most of that goes on in circulation. So your organs and your cells are breaking down T4 into T3 and finally getting rid of it. Let's also talk briefly about thyroid diseases, why we're even having to worry about checking it. It's so important. Why can things go wrong with it? Well, we categorize the main diseases into the gland being underactive and overactive. There's also thyroid cancer. Won't go into that on this talk. So underactive is hypothyroidism. The most common cause for that is Hashimoto's disease. Many estimate that 95 to 97% of those who have hypothyroidism, underactive thyroid gland, have it because of Hashimoto's, and that's autoimmunity. We'll talk more about thyroid antibody testing. Many with Hashimoto's do not have positive thyroid antibodies, and they never will. So that doesn't mean you don't have it. The other big category is hyperthyroidism. That's the gland being overactive. About 60-65% of the time, this is caused by Graves' disease, and that's a disease where the gland releases too much hormone. Now, hypo and hyper can also come from someone taking thyroid medications that are not the ideal amount for them. If someone needed a dosage and they were taking, say, half or a quarter of that dosage, they would be hypothyroid. They would have too little thyroid hormone to meet their body's needs. The other scenario is that if someone needed a dosage and they were taking 2-3 pills a day rather than 1 pill a day, they would be hyperthyroid. They would have too much hormone to meet their body's needs, and that's also an issue. So now we're going to get into testing, and I'm going to start talking about the main blood tests. There's a few that are less commonly used, things like T3-RIA, T4-T7 ratio, total hormones. There's a few odds and ends that have mostly gone by the wayside because they're not as helpful as some of the current tests. So I'll mention those briefly, but I won't really give them detail because they don't really deserve your time or effort. They're not around and they're really not relevant. So TSH. Now the HS is highly sensitive. So this is the newest generation of the TSH test, and it's the one that's most commonly in use. Sometimes it'll say HS or highly sensitive, sometimes it will not, but this is the one that is used in almost all circumstances. So this one, big topic, we could spend a lot of time on this. Many argue we should ignore this completely, we should jettison it from the earth and never talk about it again. And others say, oh no, this is the only thing that matters, this big broad range of it is all that's important. Both those extreme views are not correct. So we do want to pay attention to this, but at the same time, it's not all that matters. And also it does take some finesse and some thought to interpret it in a meaningful, accurate way. So this is thyroid stimulating hormone, and the pituitary uses it to stimulate the thyroid. Now this is backwards. So if you were in that hypothyroid state and your gland was underactive, this number would be higher. And if your gland is overactive, or if you're taking just too much more than you need, this number gets lower. So it's inverse. In terms of just ranges and levels, many labs say this is normal when it's between about 0.4 to 4.5. And this is probably the biggest important distinction between normal and optimal is right here. So many papers have shown that if you grab up a bunch of healthy people, screen them closely for thyroid disease, pull out the ones that have signs of it, and take everyone else who's got no signs of thyroid disease, no issues affecting their thyroid, and you check their TSH scores, they run on the bottom end of the normal range. So they're all going to be between about 0.35 and really almost all between there and 1.5. And this has been done. Studies have shown just this. So we still have the normal range that's much higher than that. And this is an issue because both testing for diagnosis, testing to see if you have thyroid disease, you're much more apt to have Hashimoto's and have symptoms when the TSH is higher than that 2 range. But then also testing for treatment, seeing if someone's on the right amount of medication or if they're satisfactorily treated, there's a lot of data saying when the TSH is also above 2, a lot more bad things happen. We have higher rates of diabetes, heart disease, many cancers, including thyroid cancer, total mortality. So both in terms of seeing who has thyroid disease and who has well-controlled thyroid disease, this range is too broad. We must think within it. We must consider an optimal level. Now the other wrinkle is that too low is also bad. And I know of many alternative practitioners who are educated, experienced, well-intended, and they argue that you can ignore the TSH when it's too low, when it's less than 0.4. And most people can, but this is one of those safety issues to where it's a numbers game. Many cannot. And I've got to say, I've seen so many sad stories of people who have come to see me after having been on a dose of medication that kept their TSH low for a period of time. And I've seen people develop congestive heart failure. I've seen atrial fibrillation. I've seen those who have had strokes from that. I've seen bone thinning and osteoporosis. And I've seen those who have died from that approach. So it is bad to have the TSH low. And many people can have it low for a while, maybe feel fine, maybe feel great. But just know that there are risks associated with that. So I would implore you to find other ways to help improve your metabolism if that's the only way you seem to feel well is with the TSH being too low. And it can be done. When you're in that state to where you only have energy when the TSH is too low, there's something else off. And we'll talk about some root causes, some root cause testing to look at, but there are solutions that can really let you have your cake and eat it too, your gluten-free cake. You can feel well and you can not be in a range of risk. That's entirely possible. Let's talk about the free T3 and free T4. let me give a quick overview about free hormones versus total hormones. So the thyroid hormones are carried throughout your body on carrier proteins. And most of the hormones are bound up permanently by those proteins. Some are loose and on a free form. They're the most active. So a free T3 tests the free T3. Now if it doesn't say free T3, well, it's actually a total T3. Sometimes it'll say total T3 or it'll just say T3. Those are both total T3s. They're better than nothing, but they're not as accurate. And the problem is because even if you know how much total T3 is there, you may have a lot of stuff that's inactivated, but you may not have enough of the active free fraction of the hormone. So the free fraction is more meaningful, and free T3 and free T4 are helpful things to test for. So the gland itself releases both of these, but mostly T4. So when we're checking these levels, what we're seeing is how much has been released, how much is circulating. We're also getting a sense about how the body's converting T4 to T3. And that's the idea, is we pull off an iodine from T4 and make it into T3. And we'll talk a bit more about that conversion. Another important test we have is thyroglobulin. Now I want to contrast. We've got thyroglobulin and anti-thyroglobulin. They're not the same thing. So thyroglobulin is a protein that's innate to the thyroid. That's part of the building block, that scaffolding that makes the active hormone. So some of it in the bloodstream is normal. A lot of it in the bloodstream means there's a high rate of cell death, high amounts of inflammation in the thyroid. This can be large nodules. This can be a sign of thyroid cancer. It's a good thing to screen for, and it's not the same as anti-thyroglobulin. You can also see this abbreviated as TG for short. Now we've got the thyroid antibodies, the main two that are commonly measured. So this is anti-thyroglobulin. So all the same stuff about thyroglobulin, but this is an antibody that attacks it, which is a common part of Hashimoto's. We've also got anti-thyroid peroxidase. That's the enzyme involved with hormone production. You know, a little trick in chemistry is that ASE means, at the end of something, means an enzyme. So this is an enzyme that works along with iodine, tyrosine, thyroglobulin to make the thyroid hormones. With Hashimoto's, the body attacks these. Now, a couple of things about the antibodies. They're not always there, even for those who have Hashimoto's, and they can be crazy erratic. We'll talk about that a bit more with testing pitfalls. And by erratic, I mean in ways that are probably not meaningful. They just go up and down based upon how the test is read and how the laboratory equipment works with them. We've also got TSI. This is thyroid stimulating immunoglobulin. This has also been called the thyroid receptor binding protein, or thyrotropin receptor binding protein. This is a test that shows Graves' activity. And when I'm first testing for someone for diagnosis, I do like to screen for this. If we see someone who has been on treatment for some time and they're stable enough, it tends not to emerge over time, but there are some that have both Hashimoto's and Graves'. And that can be someone who presents as being hypothyroid or someone who presents as being hyperthyroid. They could have a combination of those diseases, believe it or not. And this is how we know about that. This is also nice to know because the level of this TSI, is indicative of risk for Graves' eye disease or Graves' ophthalmopathy, which is important to catch and manage well. I find it ironic that Graves' and Hashimoto's are almost the same disease, and then TSI is like almost the same as TSH. So they're so different, but they're so close. You know, funny little twist that amused me at least. So reverse T3. Now T3 is the active thyroid hormone, the most active. But when the body makes it from T4, it makes two versions of that. We call this chirality in chemistry. There's a right-hand form and a left-hand form. And if you think about this like fingers and thumbs, these are the same things, but they're not. They're mirror images of each other. You know, you can't superimpose them without reversing them. They can't be superimposed. So they're different. And there's many examples in biological organic chemistry to where mirror image molecules, one does something different than the other. And reverse T3 is inactive, whereas T3 is the active of the two. Now, in most cases when reverse T3 is higher than desirable, it's just a function of the body intentionally getting rid of T3 faster. And in fact, reverse T3 is the main thing you make out of T4. You make more of it than you make T3 because there's generally a surplus of T4. But when this is too high, either your body's intentionally slowing it because there's something off and you can't really function with adequate thyroid hormone, or you're just taking too much thyroid hormone, and that's how your body is bailing out the ship. So it can be worth watching, but it's not so much an error onto itself. There have been some who have talked about problems by which people just cannot help but overconvert reverse T3. Not so much. It's normal to make. The body can control that. If it's happening, it's really happening for a reason. So it's not a matter of avoiding T4 and only taking T3. It's a matter of sorting out why there's so darn much of it and then managing those real causative factors. So that was a big discussion about the blood tests. I want to talk a bit about structural evaluation of the thyroid. That just means understanding its physical mass, its size, and its physical health. So structural evaluation, we're thinking about ultrasound evaluation, we're thinking about self-exam, and also doctor's exam. That's probably the order of importance. So many with thyroid disease have never had an ultrasound. Please get an ultrasound. Thyroid cancer is the fastest increasing type of cancer among women in North America, bar none. And it's more common amongst those who have thyroid disease. So please get yourself screened. I've had so many stories of those who have heard this message and said, wow, I've never been tested. Finally I was. Thank goodness this was caught. So if it's there, get it caught. How often? If something is abnormal, that may be every quarter, a couple times a year. If it's normal, I would encourage alternating years at least for those who are on ongoing thyroid treatment. Cool thing about ultrasounds, they're not radiation. There's no cumulative radiation to be concerned with. So they're fine, they're harmless. Next big thing there is self-exams. So check your thyroid every month. It's a simple thing. Really just drink some water, watch in a mirror, and learn to feel the structure. And you learn to know what's normal. First few times, it's probably going to feel weird, and it's not a bad idea to go to your doctor and say, hey, is that supposed to feel like this? Is this supposed to be there? And once you get confidence on what your normal is, you'll know first if that's changed in some way. Great habit to do breast self-exams for women, testicular self-exams for men on a monthly basis, and then just knock out the thyroid gland while you're at it too. So cover that one on your own. Thyroid exam by a doctor, good thing as part of a yearly overall physical, a GYN check or a routine physical exam, so helpful as well. I want to mention about some root cause tests. So along with knowing just how the basic functioning is of your thyroid and whether you're getting enough, too much, too little medication, it's nice to know what gave rise to this. This is important at the first stage of diagnosis, but also on an ongoing sense for treatment. Well, I guess with the exception of the gene test, which we'll mention, those you don't test on an ongoing basis. There are tests of gene function, gene expression, like we think about the MTHFR genes, and homocysteine as a measurement of the function of the genes. So that's good to track, but once you know your gene status for those various things, you know it, and that's done. I'll cut that one off quick first off. Easy thing is do a 23andMe test. There's so much information in that raw data that you can access. It's not always a helpful thing in terms of action steps, but if you're one that wants to go deep and advanced and know your gene status in various ways, that's the most cost-effective and efficient way to go about it. And as we learn more about certain genes and their effects, you'll likely have that data already in your 23andMe profile. So fun thing to have. Food testing, which foods are you reacted to personally? How is your gut working? Nice things to know about. GI function, this is critical in terms of just any chronic infections you could be carrying. Also the health of your microbiome, any leaky gut issues. Many will say, with autoimmunity, I must have leaky gut. Many do, but I always think about these things, not so much a matter of assume you have it, do something, hope it's better. I always say, test, don't guess. Know what's important to you, and then address that, and then know that it was resolved. Or if not, know you've got to dig deeper. So have a clear sense of what your personal needs are, address them, and then make sure they've resolved. That's the process that we've done for 20 years in the clinic, and all my doctors do a great job with. But you may not need to do everything, and you may be doing something to help something in a way that's not actually helping, or it may not be necessary for you. So focus your efforts and achieve clear, measurable, objective results. Toxicology, the thyroid's a concentrator, and there's a big overlap between building up lead, mercury, perchlorate, various toxins, and the onset and the severity of thyroid disease. So good stuff to screen for. Nutrients, vitamin D is a big one, and you may need more or less. So you got to measure for some of these things. The adrenal glands, how is that daily circadian rhythm? Are you good and thriving, or are you stressed and always overproducing cortisol, or backwards or wired and tired, or just crashed? Make sure your adrenals are dialed in and healthy. They're a critical part about your recovery too. So talk a little bit about interpreting results. I did touch on these topics somewhat, but TSH, you want to see that really at the lower end of the normal range, but not below it. So about 0.5 to 1.5 is my favorite spot. If someone does have any structural problems, like the gland is enlarged or nodular, then I'd say even narrower, like 0.5 to 0.9. Now, free hormones, some argue they should be on the high end of the normal range. Well, I alluded to some tests before in which people that are healthy and have no thyroid disease at all have had thyroid tests and their scores have been reported. Guess what? Healthy people don't have all high levels of free T3 and free T4. They've got a full range of levels of those hormones. So I don't argue that you've got to be in the high end of those ranges. And I say that because many people function great when they're not at the highest end of that range, and many, the only way they get the high end of the range is to have their TSH pushed too low. And again, that can be a danger. That can be a clear risk factor for diseases and complications. Thyroid antibodies, good to be aware of. They're squirrely. You could check them 3 times in one day and get 3 different results, so be aware of that. Reverse T3, good to be aware of. It's not one that I track on an ongoing basis all the time. When someone's first getting diagnosed or first getting evaluated, it's nice to know about the reverse T3, but by and large, when they're dialed in and stable and on appropriate amounts, the reverse T3 is predictable. A little more concept explanation here. You could test everything on everyone every time, like all the time, but at some point, you got to pay for all these tests, and you got a lot of blood loss as well. So after the points of diagnosis and knowing all the detailed stuff, it's not practical to test everything all the time. I'll talk a bit more about schedules and frequencies. So for starters, we think about testing for diagnosis, and that's pretty much all the tests that I talked about. You would cover all of those. And that way you can really see someone's baseline levels. If they've got Hashimoto's, if they've got Graves', if they're hypo, if they're hyper, evaluate their pituitary, hypothalamic function. You can see all that with those tests pretty comprehensively. And we also think about testing for dosage. So someone who's on treatment, and the question is it working well? Is it the right amount, the right type? If they've got symptoms, are they from the thyroid, or is it worth looking elsewhere to explain those symptoms? Testing for dosage, if someone's pretty stable, this can be kept focused. You can do TSH and free hormones and have a clear sense about whether they're on a reasonable amount. If they've had really high antibody levels in the past, then it may be worth also watching their antibodies if they run up in the 4 digits. If they've been lower and fluctuating, wouldn't have to be part of it. Nice to watch, but again, not something I would say you'd have to spend for every time. And then the idea is about when to test. So time of day matters. Thyroid hormones are circadian, and that means that they are different, like for me now, than they would be for me when I'm asleep. So morning is really the gold standard. So check them first thing in the morning when you wake up. And labs don't open right when you wake up, so somewhere ideally before 9 o'clock is a good time. An important distinction to make is that you want to take your thyroid medication after you've had your blood test, not beforehand. And also fasting is worth doing because you'll be checking other things as well, like glucose or lipids or whatnot. So get it fasting, get it first thing in the morning, and get it before taking your thyroid tablet. And now how often to test? Well, when someone's first getting diagnosed, you check everything. When someone first starts treatment, I actually do some very focused retests every 2 weeks for about 2 or 3 times. That's usually enough to get someone dialed in on treatment and get them steady. Typically, after they're dialed in and steady, I'll check once a quarter for 1 or 2 tests, and then afterwards twice a year. So simple schedule. At the beginning, every 2 weeks for the first 6 weeks, and that's usually just TSH and free hormones for small dose adjustments. And then afterwards, quarterly for 1, and then twice a year. With good adjustments and by treating all the root causes, it doesn't take more than that or more frequency than that for the vast majority of people. Okay, so here's a couple common testing issues. So one, comes up a lot from someone taking their thyroid before their test. So if someone's on natural desiccated thyroid, they get their blood tests and their free T3 is really high. The rest might be good, free hormones, free T4, antibodies, TSH, but the free T3 is really high. So their well-meaning other doctor says, hey, that one's not safe for you. You should take Synthroid instead. You should take a T4 only medication because this one has too much T3 for you. But the first question to ask was, when did you take your tablet? When did you do your blood? Because probably what happened was they took their tablet and had their blood draw a couple of hours afterwards. That's why the free T3 was high, because the body absorbs it. There's an absorption cycle of T3 that's not the same as the metabolism cycle of T3. So absorbing it and having it at a high level is not the same as having a high level in general. So that's just a timing issue. The other one is low TSH, and I did talk about that a few times. Low TSH is a dangerous thing, and that is worth working around. And I've taken some heat for saying that because there are some that strongly come out against this position. And it's a tough thing because there are many examples of people who feel better with a low TSH. I get that. And there are many who have had a low TSH and they've been fine from that. But my concern is that it's a numbers game. The majority of smokers do not get lung cancer. But no matter how many smokers you can find that don't have lung cancer, that doesn't disprove the fact that smokers have a higher risk for lung cancer. No single case study reverses that. And it's the same thing for a low TSH. Many have done fine with it, but many have not. And it's a risk factor, like not wearing a seatbelt. Not everyone who takes off their seatbelt is immediately in a bad accident. Most are not, thankfully. But it is a risk factor, so people should just be aware of that. And it's also worth trying to think about how else they could manage those symptoms other than just taking an overdose of thyroid. Or if their body only seems to function on overdose of thyroid, why is that? What is the deep root cause that has not been identified or not been discovered or taken care of? The two I think about the most would be toxicology and then also adrenal function, but others could be relevant for that as well. Erratic antibodies. So thyroid antibodies, they're good to confirm the diagnosis of Hashimoto's. They don't rule it out in their absence. They're also good to be aware of when they're extremely high in terms of fertility. Data has shown that if your thyroid is stable but you've got super high antibodies, that can still be a culprit for fertility. There are also some other theories about high antibodies causing various symptoms. And by high, most papers talk about in the 4 digits and above, so like thousands. For most people, they're in the 2 digits or low 3 digits. In those cases, being a little higher, a little lower, there's probably not a lot of strong implications on your health based upon that fluctuation. So when you see them wandering up and down a bit, they can do that with no meaning whatsoever. I mean, honestly, the same day you could draw many vials of blood, send them all in, and get different readings. Like one could be a 30 for TPO, anti-TPO, one could be a 200, one could be a 50. That's just how it works with them. And I've seen many people that have made, changes that could be good changes or bad changes and said, hey, my thyroid antibodies went up or down a bit. That must mean something. But it doesn't always. They can go up and down totally randomly. So just know that and don't put a lot of stock into their fluctuations at the typical levels, only at the extremes. Last big one to mention is TSH drift. Now your TSH, I talked before about my approach of checking every few weeks at first. Now, nothing levels out that fast. I just want to throw that out. You're not at a steady state. It does take upwards of 3 months for your TSH to completely reach a set point after you've made an adjustment to your dosage or made some radical positive change in your lifestyle. So please do know that. And if it's moving down in a certain direction, that may be enough to say that that was the intent that was wanted, but do know that it won't reach a steady state for some time. So it's good to have a follow-up check about 3 months out to confirm that it has stabilized. Now, the conventional approach is do nothing at less than 3 to 6 month intervals because of this. My approach is, well, if that's the case, if you're only going to make an adjustment once or twice a year, which is how it often ends up happening, it might take you quite some time to get things right. So I'd rather test more often, but just know, okay, I want to make sure the TSH is moving, but I know that it's not yet steady. So when I'm seeing someone say their TSH is 5 and I start them on treatment and I check every 2 weeks, if their first test, their TSH has come down to 1, I know they're not steady yet, and I know they're going to drift too far down. On the other hand, if they drift down to like 3.5 or 4, that's a good step. I want to keep on watching, and I should see similar incremental change. But you always got to know that TSH will drift and will level out. So big picture, thyroid testing, it's an important thing. It's not impossible to get it right and understand it. I hope this was a helpful thing for you. If you're on treatment, testing is worth doing to know if you're on the best treatment. And here's just one thing I didn't mention is that you may feel like you're low in your thyroid when you're not. So you could take more than you need, and you could have hypothyroid symptoms from that. Testing can help you distinguish. And there are those who say ignore the test, take more. But the drawback is when you take too much, your body can block those hormones, and they can make it feel like too little. So testing is not the goal. The goal is your health and you feeling better. That's the important part, is your symptoms. The symptoms matter. But the testing is a really helpful tool to know which way to turn the wheel towards the place of fewer symptoms. So hope that helps. Dr. Alan Christianson, enjoyed spending some time with you here, and take great care of yourself.